Good morning, and thank you for joining us here today. Like Dr. Lobus mentioned, my name is Pranay Soni. I'm one of the skull-based neurosurgeons at Cleveland Clinic and the surgical director of our Cleveland Clinic NF program. And today, we're going to be talking a little bit about surgery in NF2 schwannomatosis. When do we do it, why, and what kind? So I have no disclosures for this talk. And just to quickly outline what we'll try to touch on today, first, we heard from Dr. Lobus. We'll just review a little bit about what schwannomatosis is. We'll talk about vestibular schwannomas, or acoustic neuromas in particular, some of the goals of management. We'll talk about when to operate. Then we'll move on to meningiomas, a little bit about the natural history of meningiomas, when we operate on those. And then we'll talk about Ependymomas as well. So, like Dr. Lobus mentioned, schwannomatosis, which is the newer term, sometimes we call that NF2, is a genetic condition that causes benign tumors and on the nerves and other tumors in the central nervous system. These can be schwannomas, which are those benign nerve tumors, meningiomas, which are benign tumors on the lining of the nervous system, or those spinal cord tumors. And NF2 schwannomatosis is the most common, but as Dr. Lobus mentioned, there are other kinds and other genes that are associated with schwannomatosis as well. So this is kind of a classic picture, and it's pretty obvious when you look at this MRI that we have two tumors. They're large, they're in the middle, and this is the classic picture of NF2, or schwannomatosis. These are tumors on the hearing and balance nerves, as you can see here, they're large, these white circles here, and they're pushing on the brain, which is in the middle. But schwannomatosis is a spectrum. It's not one size fits all. And so sometimes a patient's MRI may look like this, where there's smaller schwannomas, other tumors as well, maybe only small tumors in general. Sometimes the tumors can be asymmetric, where one side is bigger than the other. There can be tumors that are in different locations along other nerves. And so really it's a spectrum of disorders. And the management of NF2 or schwannomatosis really requires a comprehensive center. We need input from oncologists, neurologists, hearing doctors, audiologists, surgeons like myself, ENT specialists, ear, nose, and throat doctors, pediatricians, geneticists, and really it's a team effort. And patients with NF2 and schwannomatosis really should be managed at places that see a lot of these kinds of patients, because that experience with a rare disorder is what really helps guide the management. Now, with vestibular schwannomas in particular, let's talk a little bit about when is surgery the right option. These, again, are sometimes called acoustic neuromas. But sometimes if tumors are growing, that may be a reason for surgery. If tumors are causing symptoms, that can include things like pain, weakness, hearing loss, vision loss. If tumors are pressing on important areas in the brain, like the brain stem, which is that main highway of nerves, if it's pushing on the vision nerves, the hearing nerves, swallowing nerves, or other nerves in the brain. But unfortunately, it's not all black and white, not one size fits all. And really, for each individual patient, we have to weigh the risks and the benefits of any surgery that we are thinking about. And so with surgery, there are some times where surgery is maybe a little bit more obvious that it's a better option. That can be when patients have small tumors that are growing and patients maybe already have hearing loss. It can be if patients have very, very large tumors that are causing symptoms from compression on the brain stem. But it's a lot more challenging to decide about surgery when maybe a tumor is growing, but a patient's hearing is normal, and we don't want to risk that. And so these are where these multidisciplinary discussions with team members from all of those different team members that we talked about really come into play. So with surgery, really our goals are, number one, quality of life. That certainly starts with hearing preservation, but also includes things like functional mobility, making sure patients can move around, walk, use their arms and legs really to their fullest ability. We want to maintain that facial nerve function. That's the nerve that is very important in patients with vestibular schwannomas. Sometimes that can be affected from tumors, but sometimes it can also be affected from some of the treatments for those tumors. And same goes with swallowing function as well, though not as often as facial nerve. Tumor control is certainly a goal for surgery as well. If tumors are growing, we want to be able to treat those and prevent further growth. But we know that a cure is not really possible. This is, as we mentioned, a genetic condition. And so curing this is not possible, but really we want to maximize control of these tumors. Now, talking about hearing loss, unfortunately we know that hearing loss is expected in most patients at some point in life due to vestibular schwannomas or acoustic neuromas. And as Dr. Lobus mentioned just a minute ago, tumor growth doesn't always correlate with hearing loss. We can have small tumors that may cause hearing loss, or we can have tumors that are growing or large tumors where a patient's hearing may be completely normal. And that really plays into the decision about surgery. Medications, like Dr. Lobus mentioned, are usually the first option, the best option to prevent or sometimes even reverse a little bit of hearing loss. But surgery can be used if those medications don't work, if there's side effects from medications, or surgery can actually be used for hearing restoration. And we'll hear a little bit about that later today as well, with some of those options for hearing restoration in patients with NF2. What kind of surgery do we do for NF2? Well, this is one example. This is an example of what's called a retrosigmoid approach for a vestibular schwannoma. This involves an incision behind the ear, and through a small opening, really just about the size of a quarter, or maybe a little smaller than a quarter behind the ear, we can work around the brain where all of the nerves are located. We can see this tumor here, and we work using very, very fine instruments to remove this tumor from those nerves. And that's called a retrosigmoid approach, and that's sometimes how we remove vestibular schwannomas. Now, other surgical options for patients with NF2 include facial reanimation, and that's one of the important goals of treatment or surgery is preventing facial weakness. But we have a really spectacular facial reanimation team here at Cleveland Clinic, and that includes team members from our facial plastic reconstructive team. And what we can do, and the goal of this, is if a patient has facial weakness, whether that's from a tumor or from a treatment for a tumor, they can take a nerve that is functioning normally and reattach it to the facial nerve. And really we've seen phenomenal outcomes, as you can see here, in patients who have had facial weakness, and some of those good outcomes that we can see with these surgeries. Now, I'm going to switch gears and talk a little bit about meningiomas, which are also common tumors in NF2, and they're seen in about half of patients with NF2 or schwannomatosis. Patients can have multiple tumors, so it may not just be one meningioma. And as you can see here on this MRI, we see the schwannomas, or the acoustic neuromas here, but also these other tumors, which are meningiomas. And again, these are benign tumors from the lining around the brain. But as you can see, there's a spectrum with this as well. And we can have some MRIs where, with some patients who have an MRI that has many, many meningiomas, or maybe just one meningioma. Now, I think it's important first to understand what happens to meningiomas in patients with NF2. And this is actually a study we did here at Cleveland Clinic, looking at patients with NF2 with meningiomas. And what we found was that about 1 out of 3 meningiomas will grow after it's diagnosed in the first few years. The longer it goes, the less likelihood there is that it grows. But we found that patients who are younger, or tumors that have more swelling around them, may be more likely to grow. And that helps us know which tumors do we need to monitor a little bit more closely, which ones may have a higher chance of growing and may need treatment in the future. So when do we operate on meningiomas? Well, if tumors are symptomatic, that can sometimes be a reason to operate to help relieve some of the pressure on the brain. Or tumors that are growing and not responding to the medical options we have, or in a location where maybe they put important brain or nerve structures at risk if they grow more. And so those may be a reason to operate. So how do we do that? Well, traditionally, and probably most commonly, we'll do what's called a craniotomy. This is dependent on where that tumor is located, as it can be anywhere around the skull or even in the spine sometimes. But we remove the bone covering temporarily. We open the covering of the brain, and we remove the tumor underneath. That's called a craniotomy. But we have newer techniques as well, some minimally invasive options where we can even operate using small cameras without an incision through a patient's nose if a tumor is in that location. And sometimes even newer options where we can operate through a patient's eyelid or eyebrow. And really the recovery for some of these minimally invasive options can be much, much shorter, much easier for a patient to undergo. There are other options as well. That includes radiation, which sometimes is called radiosurgery or gamma knife. You can see a couple pictures here. Sometimes that involves a mask where really there's nothing attached to the head, or a frame that goes on temporarily and comes off afterwards. And gamma knife is a very, very focused radiation to really halt the progression of a tumor. Now that's used, say a patient has a tumor that's growing and we want to stop it from growing. Maybe it's not causing symptoms. Well, these can be very effective. And if we look at how well gamma knife can control a meningioma and stop it from growing, it's very effective, more than 90% effective. Now, lastly, I want to talk a little bit about ependymomas. These are those spinal cord tumors that Dr. Lobus had mentioned. And for the most part, these tumors typically don't need surgery. We can monitor these, and most patients won't develop symptoms from these. But we know, as we've studied these more and more, that some patients who have NF2 and ependymomas on their spinal cord may see that those tumors grow, or that they develop some neurologic symptoms from that, like weakness or numbness, tingling, trouble with walking or balance. And in those patients, surgery may be a good option to treat these tumors. And that's something else we monitor for. And though it's less common than meningiomas and schwannomas, something else we can treat with surgery if needed. So just to kind of wrap up, every patient is different. There's no one size fits all with NF2 and schwannomatosis. We really strive for individualized care, and what that means is making sure that we work with our patients, our families, each patient's MRI over time, and all of the team members really to come up with the best treatment plan at a comprehensive center like we do here at Cleveland Clinic. Really, it's a discussion for each surgery, each procedure, what the risks are, what the benefits are of that surgery. And surgery ultimately can be safe, it can be effective for the right patient, for the right tumor, and for the right time. So with that, I just want to show my references, and thank you very much.